Today it feels like a good day. I got to the point where walking was not comfortable anymore. That was the big decision to go with the knee replacement. Toughest part I'm having today is extension, but flexion was good. Feeling stronger, less pain getting up and down. Goal is a lot less pain than I used to have and being able to walk comfortably and obviously less pain.
Yeah, every patient is different. And so we try to achieve the goals of full range of motion, good strength, and walking without a limp.
Everybody here is a good cheerleader, as well as getting you to the point where you need to be.
Here to see Dr. MacArthur today.
Hi, how you doing today?
I'm good, how are you?
Good, thank you.
Good. How are you, Val? Good. Come on in. You want to get the bonds, I'll table chair, whatever looks better for you. Feel free to take a seat. All right, my friend, that's as far as my pay grade takes me. When I grab the guy you really came to see, we'll get you squared away.
Good afternoon.
How are you?
I'm good, how are you?
Last injection did what for you?
Not much, not for long. Pain just keeps coming back quicker and quicker to the point where I can't be comfortable.
All right, let me take a look.
Yeah, initially it was an ACL tear in 1987, and then reconstruction.
And since then, multiple injections over the past 11 years, right? And you've been getting pretty good relief and functioning, but you just didn't get much out of this last round.
No.
And it's been less and less. Big group that I do this surgery on, you've heard me tell you this before, 55 to 75. You're not in the big group. You're kind of knocking on the door. You're a little bit young. You don't have any other real health issues. Somebody like you, we would schedule as outpatient. So done here. That's going to be the easy day for you. The hard part's going to be the PT for the following 2 months. Your first post-op visit is going to end up being 8 to 10 days post-op, just to look at your skin, make sure your skin looks okay, adjust pain medicine if we need to. You're going to get to be very familiar with your physical therapist. Your challenge in particular is you're not able to fully extend and you're quite limited on your flexion. I'll get it flexing more than that in surgery. The huge challenge is going to be, are you going to be able to maintain that? Because when they've been like this for years, they usually want to settle back into about what they've been at.
It's time to finally get the joint replaced. So I'm here today for joint replacement. Made it through registration. Now I'm in the same day surgery waiting area, waiting to be brought back to begin the process.
You have to go right in you want?
Right.
Right about to there, and then it starts to. And you said that's only been like the last month or two?
Yeah.
Okay?
Thank you, man.
All right, I'll see you back there.
All right.
Top?
Right in the middle, and on the outside.
Okay.
Did some investigation. You have an appointment this Friday with Kathy Colby at PT here at 8:45.
She'll make me cry.
He might not remember that. You remember that, right?
I will.
Awesome.
When I had my ACL replaced, that was 10 plus years ago. She helped me with that afterwards.
Oh, okay. So what I'm going to do is ask you some questions about your past medical history, and then I'll explain the types of anesthesia I use, and you all can ask me any questions you have, okay? Yep. What I will do is I will give you some Versed through your IV, so you may or may not even remember going into the operating room. When we get in there, I'm going to have you sit on the side of the bed, and then I'll clean your back off with chlorhexidine prep, give you a little bit of a lidocaine skin meal right in your mid-back here. And then it's actually a 25 gauge needle I use. It's really petite, and I'll do the spinal for you.
Okay.
So you'll be numb from about your belly button down for about 2.5 hours. At about the 2 hour mark, you start to get some movement back in your feet, but you're still comfortable enough because we want to do x-rays. We'll give you something to eat, something to drink, and get you up with PT after that.
Sounds good.
During surgery, I'll also give you some propofol so that you sleep. You don't hear anything, you don't feel anything. You'll be breathing on your own the entire time, but you'll just be taking a nap with propofol. Perfect. Thank you. Your IV feels okay?
Yeah.
Okay, perfect. All right, now's the time for hugs, kisses, fist bumps, good wishes.
Pictures with your kids.
We'll take good care of them.
The focus at the start of therapy is to normalize their walking or their gait and really work on range of motion. Right after surgery, they are always limited with both flexion or the bend and the extension or the straightening. So those first few visits really focus on range of motion and gait.
Physical therapy is as much keeping us confident and that we're going to progress as it is working with what we get in front of us right now. Everybody's here is a good cheerleader, as well as getting you to the point where you need to be.
The patients that do have surgery here and see our inpatient therapist and then come to us in the outpatient clinic, that's great continuity of care. We know what they've been taught, what they've heard with the inpatient therapist, and then coming here, it's just an extension of what they've already learned in the beginning stages.
You were acting like you were 6 weeks out after 2 or 3 weeks.
After that first week, it felt great. I mean, I feel like I could stand up on a bicycle. I could pedal good. I was like, this is awesome.
You can get around now?
Oh, I could get around on the first day of PT. It was awesome. And that was a problem. It felt too good.
You're doing a lot, and where you started, you had such a limited range of motion. You are slowly beating it.